So this PowerPoint is going to be about the endocrine system, but just as a reminder, we wanted to make sure that you remember that there's endocrine and exocrine, and how to differentiate between the two. So that's the body's two delivery systems. So the exocrine system, basically when that's stimulated, it secretes, and it's exo because it's going to exit through usually ducts that go directly to where it's supposed to work or where it's supposed to go to. So, for example, you have your sebaceous glands, your lacrimal ducts, your mammary glands, all of that. If you look at the picture all the way to the left, that would be an example of an exocrine gland where, for example, we produce sweat and then that's able to exit straight through the duct and it goes to the top of the skin. So that's your exocrine system. Endocrine is anything that's going to get dropped into the bloodstream. So basically, a hormone will get released, get dropped into the bloodstream instead of directly to where it's supposed to act upon, and then the bloodstream will carry it off to wherever it's supposed to work. So the table on the right is going to give you just a comparison. So endocrine does not have ducts. It's going to get dropped into the bloodstream. Exocrine does have ducts, so little pathways or channels that go exactly where it's supposed to go. Endocrine is going to excrete into the bloodstream. Exocrine goes out of the duct directly to a specific site. So the big thing is exocrine is never going to go to the bloodstream. And then your endocrine secretes hormones. The exocrine, it tends to secrete almost like fluids, so sweat, tears, saliva, milk, all that good stuff. And then the distance to the target as far as like where it's supposed to act upon. The endocrine's far, that's why it's got to take the ride on the bloodstream to get where it needs to go. Exocrine's going to go directly to the site. And then that means that endocrine, because it has to travel further, the response time or the reaction time to that being released is going to be a little bit slower than the exocrine is. When we talk about hormones, we're talking about chemical messengers that the body uses to communicate. So a hormone's going to get released in one area of the body, travel through the bloodstream, like I talked about on the previous slide, and it's going to tell the cells, the organs somewhere what they need to do, when to do it, or how strongly or how much to do it. And the organs that produce and release these hormones are called glands. So each gland is going to make a specific hormone that helps control a particular function. So like metabolism, stress, growth, reproduction, or even our sleep cycle. So hormones are the messages, and then the glands are the messengers, sending those signals to keep the body in balance. This slide is a fun way to remember the major endocrine glands. So we have her powerful team always protects the precious golden palace. So your hypothalamus, which is your queen's brain, pituitary, which is your prime minister, your thyroid, which is your energy department, adrenal glands, which is your defense or stress guard, your pancreas, which is your treasury, your parathyroid, which are your builders, your gonads, which are your citizens, and your pineal gland, which is your night watch, which is going to tie into our whole story about the kingdom. So moving into the actual endocrine system, you guys need to know what the glands of the body are. And I know I struggled with this when I was a student, and a lot of people have a hard time remembering all of the glands and what they do. So I can't take full credit. I did work with ChatGPT to try to find something that would help you guys remember. So for this, we're going to go with memorizing the glands of the body. And this isn't necessarily top to bottom. They might be a little bit out of order, but it's so that the sentence makes sense. So the sentence is, her powerful team always protects the precious golden palace. Uh, her meaning hypothalamus, which is going to refer all these references like Queen's brain, Prime Minister. We're going to get into that afterwards, as our story continues. But that's a way to remember your hypothalamus, pituitary, thyroid, adrenal, pancreas, parathyroid, gonads, and pineal glands. We are going to go through each gland of the body, and at the end, we'll kind of pull this together as a story. So if you're looking at each bullet point, there's a little icon there for you. For example, the hypothalamus has a little crown there because we're referring to her as the queen. So that you have the hypothalamus. Her is referring to the mnemonic from the previous slide, just so you know which word it's supposed to be associated with. And then the queen's brain is the role in the story that it's going to have. So each bullet point for each gland is set up like that. But for your hypothalamus, it is basically controls the control center of the entire endocrine system. So it sits in the brain and just constantly monitors things like temperature, stress, hunger, and the body's just internal balance. So when something needs adjusting, the hypothalamus is going to send chemical signals to the pituitary to either start or stop releasing hormones. So in short, it's basically like the boss of the boss. So it tells the pituitary what to do, and then the pituitary from there can go ahead and tell the rest of the glands what to do. The next bullet point down is the pituitary. And so that is associated with the word powerful for the mnemonic. And then in our story, that's going to be our prime minister. And so it's basically, we refer to that as the master gland because that's the one that sends the hormones out that controls all the other glands in the body. So again, we're going to start with the hypothalamus. That's one that's going to kick it off, but the pituitary is the one that's actually going to send all these things out. So it takes instruction directly from the hypothalamus, and then it'll release hormones like TSH, ACTH, LH, FSH, growth hormone, prolactin. It does a lot of that, right? And then these hormones are going to go off and tell the organs like the thyroid or the adrenals, the reproductive organs when to turn on and off. So that will adjust their activity. So the pituitary is basically the messenger that carries out the orders from the hypothalamus to keep the body in balance. And so you can see how the hypothalamus will be the queen, and then the prime minister is one that kind of carries out all these actions. Next is your thyroid. So for the mnemonic, that's associated with the word team. And then we consider that our energy department. And so the thyroid gland controls how fast or slow the body runs. So it's going to release T3 and T4, and those regulate metabolism. They also regulate heart rate, body temperature, and how we use that energy. So if the thyroid produces too little hormones, you guys know that would be like hypothyroidism, right? The body's going to slow down, and that's where we're going to see fatigue, weight gain, cold intolerance. And then if it's produces too much with our hyperthyroid patients, your body's going to speed up, and your symptoms include anxiety, weight loss, heat intolerance. And so the thyroid is going to keep our metabolic speed hopefully in a healthy range if it's functioning correctly. Moving on, we have the adrenal glands. So those sit on top of the kidneys, and they're divided into two functional parts. You have your adrenal cortex, which makes cortisol, helps regulate metabolism, inflammation, and kind of handles the body's long-term stress response, and aldosterone. So that controls our sodium and our water balance to maintain our blood pressure, which is part of that RAS system. And then the adrenal medulla releases epinephrine and norepinephrine, which is part of our fight or flight response when we are exposed to stress or threat or anxiety or nursing school. So together, the adrenals will help the body adapt to like immediate stress and then ongoing physiological demands. Your pancreas, we talked about this a little bit, but it serves as a digestive and endocrine role. So digestive, we already talked about what that did last week, but with the endocrine system, it regulates blood glucose through the islets of Langerhans. Your beta cells release insulin to lower blood sugar by moving glucose into the cells for storage or use. And then the alpha cells are going to release glucagon to increase blood sugar by stimulating the release of stored glucose. So if you have obviously excess sugar available, it's going to secrete insulin to kind of use it or store it. And then if your sugar's lower, that's when it's going to release glucagon so that you can actually break down what was stored and have your body use it for energy. So those two hormones work like a feedback loop to keep your glucose stable and just at a functional level, because obviously we don't want it too high or too low. And you guys know if it's disrupted, like in diabetes, your body's going to lose control of its primary energy source. The thymus, which I feel like we don't talk about enough, is what it sits behind the sternum, and it's basically helps build the immune system, especially early in life. So it releases thymosin and some other hormones that help guide the immature T lymphocytes to mature and differentiate and learn how to distinguish what's the body's own cells versus like foreign invaders. So that process is really important for adaptive immunity. The thymus will gradually shrink after puberty, so it's really important, obviously, in early years developing that system. And then once the immune system has been established and kind of trained to pull of those functional T cells, the thymus just kind of chills out after that. So it acts as a training academy for the immune system's defense sources. Last but not least are our last three, which is the parathyroid, the gonads, and the pineal. So first, the parathyroid glands. They are four tiny little glands that sit behind the thyroid, and even though they're small, you don't let them fool you. So they can run the calcium economy for the whole body. They basically will release parathyroid hormone, which is PTH, and it's going to get released whenever the blood calcium drops too low. So PTH is going to tell the bones to release some of that stored calcium, and it tells the kidneys to hold on to calcium instead of peeing it out. And then it also activates vitamin D so we can absorb more calcium when we're eating our food. So they're basically the kind of the construction managers, making sure that our bones and muscles and nerves have enough calcium they need to function. Next are your gonads, and this is referring to your ovaries or testes, depending on gender, obviously. These glands will make your sex hormones. So estrogen and progesterone are made in the ovaries, and then testosterone is made in the testes. And these hormones will drive puberty, fertility, reproductive cycles, muscle and fat distribution, bone density, and even parts of mood and behavior. So the gonads are responsible for growth, development, and the characteristics that make our bodies physiologically male or female or anywhere on that spectrum. So they are the citizens of the kingdom, which kind of shape identity and legacy. So that's a little doodad for our story. And then lastly is your pineal gland. So we call that night watch because that's when it releases melatonin, and it does so based on light cues that our eyes take in. So when it gets dark, our melatonin is going to rise, and that signals the body like, hey, it's time for sleep. And then when the light returns, melatonin is going to drop so that we can actually wake up and hopefully be alert. So the pineal gland is literally like the internal clock that sets our circadian rhythm and just keeps those sleep and wake cycles on track. So your parathyroid, kind of in summation, is going to keep your calcium balanced. Your gonads are going to guide growth and reproduction, and then your pineal is going to set the rhythm for rest and recovery. All right. So this is going to be admittedly cheesy, but hopefully it'll stick because I know endocrine and hormones are kind of hard. So this is gonna be story time. So the story time slide is going to be about the kingdom of Harmonia. So you want to picture the body as a kingdom called Harmonia. At the very top, we have the hypothalamus, which is the queen, constantly watching over the kingdom and sensing what's happening, be it stress, hunger, temperature, emotions. And she sends her instructions to the prime minister, the pituitary, who communicates her orders to the rest of the realm. The thyroid, our energy department, keeps pace of the kingdom, burning smoothly, not too slow, not too fast. The adrenal glands protect the kingdom during stress and emergency, helping the body react when danger shows up and manages stress when it doesn't. Down in the treasury, the pancreas manages the kingdom's currency, which is glucose, making sure that every cell has the energy it needs, but not too much. Your parathyroid builders maintain the kingdom's infrastructure by balancing calcium so that bones, nerves, and muscles can work properly. Your thymus, our training academy, prepares the immune soldiers, which are our T cells, to identify and fight off invaders. And then the gonads, representing the citizens, create hormones that guide development, reproduction, and identity across the lifespan. And then when night falls, our pineal gland, which is our night watch, signals when it's time to rest, restoring balance and resetting the rhythm for the day. And so collectively, our endocrine system is a coordinated kingdom with each gland that has a role, and they all communicate and work together to help keep the body in balance and functioning smoothly. So hopefully that will help you guys remember this. And just remember that when one player of the kingdom is off, the whole kingdom is going to feel it, which is why endocrine balance is so important for us. So your thyroid functions off of a feedback loop, and we're going to reiterate that because that's important when it comes to hypo and hyperthyroidism. So your thyroid's going to work on a feedback loop, and that works with the hypothalamus and the pituitary. So when the body senses that T3 and T4 are too low, the hypothalamus steps in, which is your queen going, hey, T3 and T4 are too low. And then it's going to release thyroid releasing hormone, and that's what's going to get sent to the pituitary gland, which is your prime minister, the one that kind of takes orders from the queen. And the prime minister or the pituitary gland is going to release TSH, which you guys know is thyroid stimulating hormone. And then your TSH is going to travel through the bloodstream and get to the thyroid gland to be like, hey, you need to make more T3 and T4 so that we can bring our levels back up to normal. Once those thyroid hormones level rise back to where they should be, the hypothalamus and the pituitary are going to back off. They're like, okay, our levels are normal. We're done. So the hypothalamus is going to stop releasing TRH, and then the pituitary is going to stop releasing TSH, and the thyroid is going to slow down its output. And so that whole thing is a negative feedback loop. The system turns itself on when levels are low, and then off back when levels get back to normal. And so that's the body's way of keeping metabolism balanced and stable. Um, TSH chases T3, T4. So when thyroid hormones are low, TSH goes up. And then when your thyroid hormones are high, your TSH goes down. And that's going to be helpful when we talk about checking our TSH level on our patients who have dysregulation. Hypothyroidism means that thyroid is making and releasing more thyroid hormone than the body needs. So the thyroid itself is actually releasing too much T3, T4. The most common cause for this is Graves' disease, which is an autoimmune condition, but it can also happen if your patient has thyroiditis, excess iodine, or even certain meds like amiodarone, which is a little bit scary because we give that all the time. Because the thyroid hormones control metabolism, everything in the body is going to start running too fast. You're going to see heat intolerance, rapid heart rate, so they'll be tachycardic, excessive sweating, nervousness, irritability. They might have some tremors. So the thyroid might become enlarged into a goiter. And in Graves' disease specifically, you're going to see that exophthalmos where those eyes bulge like they do in this picture here. And then when we check our labs, we're going to see that our TSH level is low. So in that case, what's happening is the pituitary is trying to shut things down. It's like, hey, our T3, T4 are too high. You're overacting. And so like they're trying to back that off. And then your treatment, as far as what we're going to do for these patients, is you're going to have an overall goal of trying to slow things down. So you definitely want to slow down thyroid hormone production. So you want that T3 and T4 to drop. There are anti-thyroid medications like methimazole and PTU, which I could try to say it, propylthiouracil. So that's why we call it PTU. And those are used to block hormone synthesis. And then we can also use iodides to temporarily reduce some of the release of the thyroid hormone. And then beta blockers will help control symptoms like that rapid heart rate and tremors and anxiety when those levels kind of control the symptoms while we get those levels under control. Moving on to thyroid storm or thyrotoxic crisis. It's basically a medical emergency. It's when your body is going to suddenly release a massive surge of thyroid hormones, and then that's going to create a really extreme hypermetabolic and sympathetic nervous system response. So most cases happen the patient has already had a history of hyperthyroidism, especially if it's Graves' disease, and that can get triggered by stress. So let's say we have underlying Graves' disease and then we have an infection or trauma or surgery, or they suddenly stop their medications. Because thyroid hormone controls metabolism, everything's become very, very overstimulated. So the patient can have high fever, severe tachycardia, they'll have dysrhythmias, hypertension, and that blood pressure per usual will be elevated and then it'll eventually crash. And then those patients might be restless or confused, and then this can actually end up resulting in heart failure or pulmonary edema. So your patient's basically in a full-blown fight or flight that they can't get out of. So your diagnosis is just going to be clinical. So you're going to see hyperthyroid signs, and then you'll start to see CNS changes to where they might be agitated, delirious. They may even have like a seizure. And so for our job, we just need to have like rapid supportive management. So you want to cool the patient because that high temperature can cause damage. So cool your patient, cooling measures, add a fan. We can give fluids, we can try to correct the electrolytes as soon as we can. And then using beta blockers just so we can chill out that sympathetic nervous system a little bit, slow the heart rate and the blood pressure. And then we're definitely going to give those medications we already discussed, like the methimazole or PTU, just so we can stop any new hormone production while we're trying to regulate everything else. And then afterwards, iodides should be given after an antithyroid medication to block the release of any kind of stored hormones that they might have. So if your medical therapy fails or your thyroid is severely overactive, like we're just kind of stuck, then we'll definitely switch to a thyroidectomy. And we're going to monitor for any kind of airway swelling, hypocalcemia, and vocal cord changes after that if we were to do that. So what you guys need to walk away with is that thyroid storm is a life-threatening surge of T3 and T4 too high in the system. And then your beta blockers are going to help stabilize your patient while we try to shut down that hormone production. On the other side of the spectrum, we have hypothyroidism. So that means our body has low levels of thyroid hormone, so that T3, T4. And because that thyroid hormone controls metabolism, now we're going to slow everything down. So there's two main types of that hypothyroidism. One is primary and one is secondary. for primary, that's when your thyroid gland itself can't make enough hormone. So that's your most common. And then secondary is going to be when the thyroid's fine, but the pituitary hypothalamus isn't signaling it properly. So, like we talked about, um, we need to have, if T3, T4 are low, my hypothalamus is going to catch on to that, tell the pituitary, hey, do your job, and then that's going to go down to the thyroid to make more T3, T4. So in your secondary hypothyroidism, the thyroid is able to do its job, but it's not being told to do its job by the hypothalamus and pituitary. So the number one cause in developed countries for this is Hashimoto's thyroiditis. And that's just an autoimmune condition where the immune system gradually starts to attack the thyroid. And then in some parts of the world, iodine deficiency is your leading cause. So we can see hypothyroidism from certain medications like lithium as well. And you guys know, hopefully, that that's part of treatment for patients with psychiatric conditions. And then in some cases, after a thyroid removal or cancer treatment, we might have this issue as well. So because your metabolism slows down, you're going to see a lot of symptoms like fatigue, cold intolerance, hair loss, constipation, weight gain, and a slower heart rate. And patients often describe just they feel like they're moving through mud mentally and physically. Um, the diagnosis involves reviewing their symptoms, so looking at their family history because it often runs in the family. It's a genetic issue, and then ordering thyroid labs. And then your imaging, we could do an ultrasound or a thyroid uptake scan. So that might be another way to help confirm our diagnosis. And the treatment's really straightforward. This is the one that we're probably used to seeing, that we're just going to give Synthroid or levothyroxine, which is just a replacement form of T4. So the key is dosing carefully and monitoring the levels over time just to get that patient back into balance. So overall, your hypothyroidism is the opposite of hyper. Obviously, we're going to slow everything down and then just replace what's missing. On the extreme side of our hypothyroidism is a myxedema coma. So that's a life-threatening emergency that occurs in patients with long-standing severe hypothyroidism when that body can no longer maintain homeostasis. So it's not actually a coma every time, but that metabolic slowdown is so profound that the body can definitely start to shut down. So the condition is usually triggered by something stressful. So again, some kind of infection, surgery, trauma, or even if they just stop their thyroid medications. So the patient already has hypothyroidism, and then you just got something else that's just going to push them over the edge and kick them into this condition. So because the metabolism controls every system, everything becomes critically slow. So you're going to see hypothermia, lethargy, altered mental status, decreased respiratory drive, hypotension, bradycardia, and they're going to start to look kind of shocky. And then that respiratory and cardiovascular system are definitely at risk for failing. So again, it doesn't always present with a coma, but you can see how we quickly hit that state with this. Diagnosis is going to be based on clinical presentation in labs. So we're obviously going to look at our TSH, T3, T4, and then definitely our electrolytes and creatine kinase just to look at what's going on metabolically with these patients. And then this is a treat now, confirm later situation. So if we really think that this is the situation, we need to start correcting things as soon as possible. So we want to do a rapid thyroid hormone replacement. So we might actually do IV Synthroid, and then we're going to do supportive care just to stabilize breathing, blood pressure, temperature. So anything we can, if they are too cold, we're going to put them on a bear hugger, blankets, try to warm them. If respiratory condition is just, not doing well, we can always intubate them. So we're just going to give supportive treatments. And then obviously we want to treat the underlying trigger. So if it's like infection or trauma, we want to get that addressed and stabilized. So your key takeaway is that your myxedema coma is a severe hypothyroidism gone critical, and that the body is too slow to sustain life. So we need immediate thyroid hormone replacement and supportive measures just to save the patient. So your metabolism is just so slow that they can't sustain vital functions, and we need to fix this right away. All right, Cushing's disease. So that refers specifically to too much ACTH, which is being released from the anterior pituitary. And so ACTH is your adrenocorticotropic hormone. And that what happens is too much is getting released from the anterior pituitary. And then that's going to signal to the adrenal glands that they need to make more cortisol, which is going to be excess cortisol. So when we say Cushing syndrome, we're talking about like an overall state of very high cortisol. I can't talk today, sorry. And that can either be caused by the body making too much on its own or by taking steroids for a long period of time, which you'll see maybe in like your chronic respiratory patients. So we're going to categorize these as either exogenous or endogenous. Exogenous is going to be your most common. So that's going to happen when your patient's just on those long-term steroids, like I just said, with your methylprednisolone, prednisone, or solumedrol. So that's your most common cause of your exogenous. Your endogenous means the body itself, like endo inside, the body itself is producing too much ACTH or cortisol, and that's usually from some kind of pituitary tumor or possibly an adrenal tumor. So because cortisol is involved in metabolism and your stress regulation, when you have too much, it causes the body to store fat differently. So instead of gaining weight evenly, these are those patients where you're going to see central obesity, like all up in, in the abdomen there. You can see in the picture on the right. You have that moon-shaped face and then the buffalo hump. So the moon-shaped face is obviously a roundness in your face. And then that buffalo hump is that weird, that sounds mean to say weird, I apologize. That larger hump on the back of the neck that we don't typically see. So you're going to see it between the shoulders. And then their skin will start to become really thin and fragile, and they'll start having purple stretch marks. They might bruise easily. They're going to have poor wound healing. We might see some high blood sugar, high sodium levels, so hypernatremia. They could have muscle weakness, excess hair growth, and then they might have gynecomastia in men just because that cortisol is going to affect your sex hormone balance as well. So the main idea with this one is that too much cortisol is going to throw the body into stress mode. Um, like a constant stress mode, and over time that's going to change how that body uses glucose and stores fat and maintains the muscle and the skin. So everything is going to get really round, it's going to be slow to heal, and your sugar is going to be high. And that kind of falls in line with, like, when we give somebody respiratory distress and we give them solumedrol, and then that's going to jack their blood sugar up. This is kind of like they're stuck in that state. So for diagnosis, we can do a dexamethasone suppression test. We could look at the adrenal glands, especially if we're worried about some kind of a tumor. And then we could also do some kind of imaging or MRI of the pituitary gland. If they are on steroids, we definitely want to taper them off. If there's any kind of cancer or tumor that's kind of throwing things off, we're going to get that removed. And then we might need to do some radiation therapy as well. Next up, we have Addison's disease or adrenal insufficiency. So Addison's is when your adrenal glands are not producing enough cortisol. So this is obviously the opposite of the previous slide. So it's not making enough cortisol and aldosterone. So your cortisol is going to regulate your stress response and your metabolism. Your aldosterone helps the body hold on to sodium and water, and that's part of your RAS system, so it's definitely important. And so when both of those are low, your body can't maintain a blood pressure, a blood sugar, or fluid balance. So with this one as well, there's going to be a primary and a secondary. Your primary adrenal insufficiency is going to happen when the adrenal glands are damaged. So that's mostly commonly due to like an autoimmune disorder where the system's going to attack its own adrenal tissues. Your secondary is going to be when there's not enough ACTH that's coming from the pituitary. So your adrenal gland is never getting the signal to produce cortisol. And that again can happen from pituitary tumors, possibly surgery, trauma, or chronic steroid use, because those steroids can suppress the pituitary as well. So because cortisol and aldosterone are low, everything in your body is going to slow down and get really weak. So that's why they have that picture of that frail lady off to the right. They will be tired. They're going to have weight loss, so they tend to be thin. They can have nausea, vomiting. You're going to have that low blood pressure, low sodium, due to your issue with your aldosterone, and then high potassium, which anytime we have high potassium, now we're looking at possible, cardiac dysrhythmias, and that's a whole nother bucket of problems. So your body may even start craving salt just because it's trying to compensate. One of your classic signs in primary Addison's is hyperpigmentation, so that's why she's colored the way that she is. Especially in the skin creases or mucous membranes, and that's going to happen because your body's overproducing ACTH in an attempt just to stimulate your adrenal glands. For diagnostics, we're going to look at labs like cortisol, sodium, potassium, and we can do tests like the ACTH stimulation test just to determine if the adrenal gland can even respond to ACTH. And then your treatment's just straightforward, same as Previously, we were just going to replace, if something's low, we're going to try to replace what the body's missing. So we can actually give cortisol. Sometimes we can give aldosterone, and then we definitely want to correct those electrolytes and those fluids just so we can stabilize blood pressure and metabolic balance. So overall, you just have too little cortisol and too little aldosterone, and we're going to see people that are weak, hypotensive, low sodium, high potassium. Pheochromocytoma. So that's a rare tumor of the adrenal medulla, and that's going to come from the chromaffin cells. That's where it got its name from. And it causes the gland to release excessive amount of catecholamine, so specifically epinephrine and norepinephrine. So you are just dumping these fight or flight catecholamines into the system. So their exact cause actually isn't known, but there is a strong genetic and family link for it. So patients with this condition can have a hereditary pattern or like associated genetic syndromes. But because so much epinephrine and norepinephrine is circulating, these patients are going to develop severe hypertension. It's just like opening a bag of Levo into their vasculature. It's not good. So they'll have severe hypertension. They can have episodes of hypertensive crisis, obviously, and then they might have headache, anxiety, sweating, chest pain, palpitations. You got to think if you're just sitting in your chair and then somebody, bolused you some Levo for no reason, that's not going to feel good. So that's what these patients look like. A key clinical clue for us is that their blood pressure is unresponsive to any kind of hypertensive medications because the problem is a hormone issue and not a vascular issue. So if I give you an antihypertensive, we'll try to maybe vasodilate. And if it's not a vascular constriction or vasodilation issue, this isn't going to work. So we have to fix the hormones. For diagnosis, we do it with a plasma-free metanophrine or a 24-hour urine test, which is followed by imaging to locate the tumor. So your definitive treatment with this one is we just have to get rid of that adrenal gland. But it's really critical what we're doing in the meantime. If we suspect it and you're doing, the 24-hour urine test or imaging to try to find it, we want to make sure we're supporting that patient as much as possible because we need to control that blood pressure with alpha blockers, especially before any kind of a surgery because we don't want them to have a hypertensive crisis during surgery. So your big thing with the pheochromocytoma is just it's an adrenaline overdrive. They'll have severe hypertension, and we basically just need to take out that gland as soon as possible. All right, type 1 diabetes. I put this at the end because I really hope you know this already. Type 1 diabetes is an autoimmune disease where the body's immune system attacks and destroys the beta cells of the pancreas. So it's not something that we acquire through diet. This one is their body's doing it to themselves. The immune system is going to attack your beta cells, which are in the pancreas, and those are the ones that are going to make your insulin. So they can't make insulin. Without that insulin, that glucose can't go from the bloodstream into the blood cells. So your glucose levels in the blood are going to rise. And it's just kind of interesting because you have all this glucose sitting in the bloodstream and your cells cannot use them. So they're just starving for energy. So a lot of times this type 1 is going to be diagnosed in children and young adults. Um, and these are the ones that are just going to need insulin for life. Like their body can't make it and we have to supplement it. So because the cells can't use glucose, the body's going to try to get rid of that extra sugar through the kidneys, and you're going to have polyuria, polydipsia, and since the cells are still hungry, that person's going to experience polyphagia. So they're going to be hungry a lot, but they're still losing weight. So other symptoms can be blurred vision, weakness, mood changes, fatigue, all that stuff that we would typically see in a hyperglycemic patient. For us, we're going to diagnose via an A1C, fasting blood glucose, or possibly a random glucose. And then once it's diagnosed, treatment focuses on just replacing that insulin through injections, or a lot of times these people end up with an insulin pump, and then maintaining blood sugar levels throughout the day. For us, fluids are going to be critical, especially while they're sick. Hopefully you guys know about like the diabetic sick day treatments. If you don't know about that, make sure you look it up because there are special education we need to give these patients when their body's stressed. So I'm already type 1 diabetic and then now I have bronchitis and I don't feel good. There's special considerations that they need to do to manage themselves at home. And we just want to make sure that we're preventing dehydration and DKA. So the key idea is that in type 1 diabetes, there's just no insulin. The body cannot use glucose, and that insulin has to get replaced for survival. And it's a long-term issue. And this is really difficult with your they get diagnosed as a child or a young adult, and it's hard to get them to buy in and really understand how serious this is if they don't manage it. So we've had a lot of, especially like teenagers in early 20s, where they're just like, you know what, I'm tired of living my life under this strict rule, so I'm going to eat what I want, and they don't really manage their diabetes, and they end up in the hospital very quickly. So, extensive education for them at their level and including their parents or the caregivers is really important for these patients. This slide is on type 2 diabetes. Hopefully, you've heard of it. Um, it is a chronic metabolic disorder where your blood sugar stays consistently high, usually because your body has developed insulin resistance. So basically, you guys already probably know this is from high carb, high sugar diet, high just living in America diet, and that blood sugar's too high for too long, and your pancreas is still going to make insulin early on, but the cells will no longer respond to it effectively. So basically, your cells are just kind of like, hey, I'm tired. So over time, your pancreas will also wear out and produce less insulin. So initially, the pancreas is going to make enough insulin to try to keep up with it. But your cells that are supposed to respond to that insulin so that they can utilize that glucose for energy, they're just getting really tired. It's like a nagging parent. It's like, yeah, I know. So the cells get less responsive, and then your pancreas is like, I'm tired of cranking out all this insulin. And so it's just going to slow down as well. So type 2 diabetics account for about 90% of all diabetes cases. That's one that we're definitely more familiar with as providers, or healthcare providers, and it's strongly linked to obesity over the age of 45 and sedentary lifestyle. So those are your common relations there. And when the body's constantly exposed to high blood sugar from poor diet and low activity, it's just going to be less responsive. And it's like you just constantly ringing a doorbell, and you're just like, I'm not going to answer the door anymore. So these symptoms, they are going to be similar to type 1. They will have the polyuria, polydipsia, polyphagia. And just to be abundantly clear, polyuria is they have excessive urination. Polydipsia is they're very, very thirsty. And then polyphagia is they're very hungry. And same as the type 1 diabetes, they can have blurred vision, fatigue, mood changes. We can end up with seizures. And then in some cases, they might have unintentional weight loss if that blood sugar stays super high, because that sugar is in the blood. They're not able to use it for anything. So diagnosis, same thing. We're going to do, our hemoglobin A1C is going to be our best bet. Our treatment is going to be on improving insulin sensitivity. So I want my cells to be more responsive to the insulin it comes across. And I want my pancreas to be able to make the insulin it needs to. So for this, we could do oral medications, injectable. Really important to keep these patients hydrated, and then diet and exercise. And really, I if you can't break this down as a student and a future nurse, if you cannot break this disease down in a very simple way where you can really get a 15-year-old to understand this and buy in and get it, then that means you don't understand it well enough. Because granted, we're teaching adults about this a lot of the times, but depending on their background, we need to take this very common, very serious disease and be able to explain it in a way that people can understand, because you guys have probably already seen previous this semester that hypertension and diabetes are like your precursors to everything else. So if we can get people better educated and get this better controlled, hopefully it'll help the patient. It will extend their lifestyle. It will reduce complications. And then it's actually going to take less of a toll on the healthcare system in the meantime. So when DKA and HHS, which is your hypermolar hyperglycemic state, it used to be HHNS, which was a non-ketonic state, insinuating there's no ketones present. With both of them, they're hyperglycemic emergencies, but they're going to happen in different types of diabetes. And they are supposedly look very different in the body. DKA is more common in type 1 diabetes, and that's when there's little to no insulin available. So without insulin, your body can't use that glucose for energy. It's going to start breaking down fat instead. And then that fat metabolism is going to create ketones, which are acidic. And then that patient's going to go into metabolic acidosis. So that's when you're going to see your Kussmaul's breathing, your fruity acetone type breath. They might have some stomach pain, polyuria, polydipsia, like we talked about, definitely dehydrated. And this is going to develop super quickly, like within a couple hours. HHS is actually more common in type 2 diabetes, where your body still has some insulin, but not enough to really use that glucose effectively. But because there's a little bit insulin present, that fat metabolism doesn't occur. So they're not going to have the ketones and the acidosis. Instead, your blood sugar is going to get extremely high, and your blood will become very thick and hyperosmolar. And then that patient's going to become progressively dehydrated and confused, and they can get to a point where they're actually comatose. But this will develop a little bit slower over a couple of days. So in terms of treatment, both require aggressive fluid resuscitation, and that's because your dehydration is severe in both. In DKA, is when we give IV insulin to stop the ketone production. And we carefully monitor and replace our potassium because anytime you're giving insulin, that potassium is going to shift into the cell, and then they're going to have really low potassium levels at that point. So we're going to have to replace that. In HHS, your fluids and electrolytes corrections come first, and then that insulin can be used a little bit more carefully later, because your problem is going to be more dehydration and hyperosmolarity before an insulin deficiency. So that's kind of the difference between the two. So DKA is type 1. They have ketones, they're acidotic, and there's a quick onset. Your HHS is type 2, no ketones. They're going to have really high blood sugars, and it's going to be slower onset. And then with both of them, we're definitely going to do like fluids first, insulin as needed, or as appropriate for the situation, and then we're going to watch those electrolytes and mental status closely.